Welcome to this presentation. It is the first of several on the concept of the single common chamber, because this is such a very, very important concept. So, let's get started with this introductory presentation. Here we see a four-chamber view of the heart showing how a closed mitral and tricuspid valve in systole separates the left atrium from the left ventricle and the right atrium from the right ventricle. Now, in this diagram, at the onset of diastole, the valves cannot be clearly seen, and there are no clear distinctions between the atrium and the ventricle in diastole. The atria and their ventricles have become a single common chamber. In diastole, I do not refer to the left atrium or the right atrium or left ventricle or the right ventricle. I refer to the left or right heart because functionally they are a single chamber. Study this diagram. It is a generic diagram that applies to both left and right ventricles. In diastole, the mitral or tricuspid valve is open and the aortic and pulmonic valves are closed. So, at the beginning of diastole, there is a pressure gradient from the veins to the low pressure in the ventricular cavity, which causes venous blood to rush into the ventricles, but towards the end of diastole, these pressures have equilibrated and tend to become equal because the mitral and tricuspid valves are wide open throughout. In fact, from the perspective of the heart, it is as if the aorta or the pulmonary artery did not exist. The ventricles in diastole are essentially super relaxed, very compliant, spherical bags of muscle designed purely to drain and decompress the venous system during diastole. So, for the right side of the heart, because the tricuspid valve is wide open, the vena cava, the right atrium, and the right ventricle in diastole are all functionally a single common compartment, but I like to use the term single common chamber in diastole. At the very instant of the start of diastole, and just before the mitral or the tricuspid valve opens, the pressure in the right ventricle may be as low as 2 millimeters of mercury, but after the tricuspid valve is fully open, the venous blood rushes through the right atrium into the right ventricle, and all three regions, both the vena cava, the right atrium, the right ventricle, they all equilibrate towards the end of diastole to a pressure of about 5 millimeters of mercury. The same situation pertains for the left heart, with the pulmonary veins having a pressure of 6 to 12 millimeters of mercury. The left ventricular pressure at the moment of the onset of diastole is low, but as the mitral valve opens and blood passes from the pulmonary veins through the left atrium into the left ventricle, the early diastolic pressure rises. It may start at 6 and rise to 12 millimeters of mercury approximately, but it is usually in the range of 6 to 12 millimeters of mercury in health. Now in systole, of course, the mitral or tricuspid valve is closed. The aortic valve is open, and as the left ventricle and the proximal arterial compartment become a single common chamber with equalization of pressures, because the mitral valve is closed, the vena cava or the pulmonary veins remain at low pressure. There is no way that the high pressure in the ventricle can be transferred to the low pressure venous side of the circulation. We see that during systole, it is almost as if the venous system did not exist. The ventricle is in series with the arterial system, and in systole, its role is to generate a high pressure by ejecting a normal stroke volume of blood into the arterial system, thus increasing the pressure of the entire system. And in this image, we see the right ventricle with an open pulmonic valve in continuity with the pulmonary artery, and the right ventricle and the pulmonary artery systolic pressure has equilibrated to 25 millimeters of mercury. The filling pressures of the vena cava and the right atrium remain low at about 5 millimeters of mercury because these are protected by a closed and competent tricuspid valve. On the left side of the heart, we see the left ventricle and the proximal arterial compartment at high pressure of 120 millimeters of mercury, because once again the aortic valve is wide open and the left atrium and the pulmonary veins are protected from this high pressure because the mitral valve is closed and competent, and the pressure in the pulmonary veins remains low at approximately 6 to 12 millimeters of mercury. Now, in a clinical context, we can insert a long vascular catheter through the femoral artery, up the abdominal and thoracic aorta, and into the aortic arch, and then we can measure left ventricular cavity pressures and central aortic pressures, and these are shown here. We can advance the catheter through an open aortic valve and into the left ventricle, and we see this trace. The left ventricular pressure trace has a systolic of 120 and a diastolic anywhere between 6 and 12 millimeters of mercury in a healthy patient, and here I have arbitrarily chosen a diastolic pressure of 8 millimeters of mercury just for illustration. So left ventricular pressure is 120 over 8, and the left ventricular pressure trace is shown as a light brown trace in these images and the movie you see before you. In diastole, the mitral valve is open, the aortic valve is closed, and we see that the instantaneous pressure in the pulmonary veins in the left atrium and the left ventricle in diastole is in the range 6 to 12, and again we're using the representative value of 8 millimeters of mercury to illustrate our point. The pressure in the central aorta, however, is much higher. It's 80 millimeters of mercury, so 10 times higher. This is the single common chamber for the left heart in diastole. In this image, we see the single common chamber for the left heart in systole. The pressures in the pulmonary veins and the left atrium remain approximately about 8 millimeters of mercury, but they can be anywhere between 6 and 12 millimeters of mercury in a healthy person. Now remember, in systole, the mitral valve is closed, the aortic valve is open, and the peak systolic pressure in the left ventricular cavity is 120, and so this must be the same pressure in the aorta, and all the arteries all the way from the large arteries all the way down to the third order arterioles, but not including the fourth order arterioles. So this proximal arterial compartment extends from left ventricular cavity to the fourth order arteriole, and so this pressure is the same in the aorta and all the arteries. So this proximal arterial compartment extends from the left ventricular cavity and ends at the fourth order arteriole, and so all these arteries and arterioles have the same systolic pressure throughout systole. This is a single functional chamber, and I call it the single common chamber for the left heart in systole. The systolic pressure is 120 millimeters of mercury. Then, as we watch this movie, we can withdraw the catheter from the left ventricular cavity in the ascending aorta, and when the catheter is pulled back, we see the sudden change. We see a typical aortic pressure trace, which is 120 over 80. So a sudden jump in diastolic pressure from 8 to 80, and the central arterial pressure trace is shown in bright red in this still image. For emphasis, in diastole, the ventricular pressure is approximately 8 millimeters of mercury, but on the other side of the aortic valve, it is 10 times higher at 80 millimeters of mercury. So, in diastole, the left heart and the central aorta are not a single common chamber. They are two very different chambers indeed. And this remains true as long as the cardiac valves in that ventricle remain competent. Let's continue our approach of using various cardiac imaging modalities to visualize the heart in the hope and expectation that it will reveal some of its secrets of cardiac function. First, let's consider the right heart. In one of our previous movies, we used left ventriculography to understand left ventricular volumes and pressures, and now we are going to study a right ventriculogram, also known as a right ventricular angiogram. Here, a pulmonary artery catheter, also called a right heart catheter, has been inserted into the femoral vein, and the balloon at its tip has been inflated, and then the catheter is advanced from the femoral vein into the inferior vena cava, and the balloon tip is carried by the blood flow into the right atrium and from there into the right ventricle. And here you can see the inflated balloon at the very tip of the catheter in the apex of the right ventricle. Here are some of the important structures you have been looking at in this movie. Now, in this movie, the contrast dye only outlines the right ventricle, the pulmonary artery and its branches. However, the right atrium, the SVC and the IVC are not well seen, but their positions are shown in this image. The gentle curve of the tricuspid and pulmonic valves are well shown, and these are very important structures indeed in understanding the important concept of the single common chamber. The orientation of the video may be puzzling to you, but we are looking at the right heart from the right-sided oblique orientation. So study this image just to be sure you have the correct orientation for the anatomical structures. And here we see what I like to call the single common chamber of the right heart in systole, and we must emphasize that this is very distinct from, very different from the single common chamber of the right heart in diastole. To explain this concept, consider this. Let's talk about the right ventricle. In diastole, the tricuspid valve opens. There is free communication between the superior and inferior vena cava, the right atrium and the right ventricle. They are functionally a single common chamber. In diastole, the right atrium and the right ventricle constitute the right heart. In diastole, as the tricuspid valve remains wide open, the pressures throughout must equilibrate. If the central venous pressure is 5, then right atrial pressure is 5, and right ventricular diastolic pressure must also be 5. So the beauty of the single common chamber concept is that if you know the value of the CVP, you also automatically know the right atrial pressure and the right ventricular and diastolic pressure. In systole, the rising pressure in the right ventricle closes the tricuspid valve. The pulmonic valve then opens. Now, the right ventricle, the pulmonary artery and the pulmonary capillaries form functionally a single common chamber. The right ventricle generates a peak systolic pressure, which is usually about 25 millimeters of mercury, and rapidly equilibrates through the right ventricle, the pulmonary artery and the pulmonary circulation. So right ventricular systolic pressure and pulmonary artery systolic pressure must be the same. So think of the diastolic right ventricle as a blind-ending sac which initially drains and decompresses and ultimately equilibrates with the right atrium and the central veins. In systole, the right ventricle transitions to a powerful pump which ejects blood into the pulmonary artery and pressurizes, and ultimately these pressures equilibrate between the pulmonary artery and the pulmonary capillaries and the right ventricle. Now, let's perform this same exercise for the left ventricle. Now in this movie, we see the right heart angiogram again, with which we are familiar, but we're going to let the video run on until we see the intravenous contrast outlining the left side of the heart. Here we see first a brief phase outlining two of the pulmonary veins, then we visualize the left atrium, then the left ventricle, and finally the contrast arrives in the aorta. And this video also serves to give us a good understanding of the speed at which blood flows from the right ventricle to the left ventricle through the pulmonary circuit. Also, we now see the left ventriculogram performed with a catheter inserted via a femoral artery up the abdominal aorta into the ascending aorta. The tip of the catheter passes through the aortic valve and into the left ventricular cavity. This image defines for us the left ventricular single common chamber which occurs in systole. And moving on to the next image, we see the left ventricular single common chamber which occurs in diastole. And once again, these are two distinct chambers. Now, for those of you who watched to the very end of the video, you may have just caught a glimpse of a little flush of retrograde contrast material leaving the ventricle and going backwards into the left atrial appendage. And this is a brief episode of mitral regurgitation. Now, having viewed these videos and still images, we can now move on to the next part of the talk, where we analyze the details and the implications of the information we have obtained so far. In diastole, the mitral valve opens. There is free communication between the pulmonic veins, the left atrium, and the left ventricle. And this is because, of course, the pulmonic veins do not have functional valves. Again, the pulmonic veins, the left atrium and the left ventricle, form what is functionally a single common chamber. And I refer to this, the left atrium and the left ventricle, as the left heart. And in diastole, the pressures in the pulmonic veins, left atrium and left ventricle must all equilibrate. In diastole, I like to think of the left ventricle as a blind ending sac of muscle which initially drains and decompresses the pulmonary veins, and the pressures ultimately equilibrate between left atrium and pulmonic veins and left ventricle. In systole, the rising pressure in the left ventricle closes the mitral valve. The aortic valve then opens. The left ventricle, aortic root and proximal arterial system form functionally a single common chamber. The left ventricle generates a peak systolic pressure of about 120, which rapidly equilibrates throughout the LV, the aortic root, and the entire arterial system as far as the resistance arterioles. So, left ventricular systolic pressure and aortic systolic pressure must be the same. In systole, the LV is a powerful muscular pump which ejects blood into and briefly equilibrates with the pressures in the aorta and the arterial system. In summary, in diastole, the ventricular cavity pressure equilibrates with the venous system draining and decompressing the veins it serves. In systole, the ventricular cavity pressure equilibrates with and pressurizes the arterial system it serves. This is a really important concept, and if you understand it, it will make the job of remembering the pressures on the right side of the heart and the left side of the heart so much easier. There's a lot less information to take in if you understand this concept of the single common chamber. Thank you for watching.